You know that moment you get your routine blood test results back from the clinic?
Oh, yeah. The classic printout.
Right. You're staring at this list of disparate numbers, like your fasting blood sugar, your cholesterol, or maybe you just had your waist measured and your blood pressure checked.
It just looks like a bunch of random scores.
Exactly. But have you ever wondered how all those isolated numbers actually talk to each other? Like, what is the hidden conversation happening inside your body while you're just going about your day?
I mean, it's a conversation we rarely pay attention to until something actually goes wrong, you know?
Yeah.
We tend to view those numbers as entirely separate grades on a health report card. If your blood pressure is high, you think, oh, I have a blood pressure problem.
Right. Or if your blood sugar is elevated, you just think you have a blood sugar problem.
Exactly. But biologically, they
Yeah.
are deeply, deeply intertwined.
Which brings us to the core of the medical stack we are doing a deep dive on today. We're looking at a massive collection of medical history, institutional guidelines, and biological research surrounding what the medical world calls metabolic syndrome.
It's a huge topic.
It really is. Our mission today is to unpack how obesity, blood sugar, and blood pressure all combine into this singular, invisible physiological cascade.
Right, because we need to look well past those surface-level numbers you see on a lab report. We want to see the hidden biochemical connections that drive this specific cluster of risk.
And what's wild is that, perhaps most surprisingly, we're going to explore why the world's top doctors and medical institutions still, to this very day, cannot actually agree on what this syndrome even is.
Yeah, that's the part that always shocks people.
The complexity here is just incredible. So we're going to break down why this diagnostic label is so controversial, and most importantly, why understanding this cascade changes everything about how you should view your long-term health. So before we get into the controversy, what are the actual metrics we're talking about here? Like, when a doctor looks for metabolic syndrome, what exactly are they checking?
So they're looking for a specific grouping of risk factors that tend to show up together. There are 5 core factors in this cluster.
Okay, 5 factors. What's the first?
First is abdominal obesity, which specifically means carrying excess visceral fat around the waist and internal organs.
Got it.
Second is elevated triglycerides, which is a type of fat in your blood. Third is low HDL cholesterol, what people often call the good cholesterol.
Right.
Fourth is elevated blood pressure. And fifth is elevated fasting blood glucose.
Okay, let's unpack this. So that's 5 distinct measurements. Do you have to have all 5 to actually be diagnosed with metabolic syndrome?
Generally speaking, most clinical definitions say you need to have at least 3 of those 5.
3 out of 5, yeah.
When 3 or more cluster together, they sharply raise your risk of developing type 2 diabetes and experiencing a major cardiovascular event, like a heart attack.
Okay, on paper, that sounds incredibly tidy. You get 3 out of 5, boom, you have a syndrome. But reading through these sources, you realize the medical establishment is essentially in a food fight over what those actual criteria should be.
A total food fight.
I mean, we're looking at guidelines from 4 major medical bodies: the World Health Organization, the National Cholesterol Education Program, the International Diabetes Federation, and the American Heart Association. And they all have completely different diagnostic thresholds.
Yeah, that is the defining illusion of metabolic syndrome. There is no single, universally agreed upon definition.
Which is crazy for something so common.
It is. They completely disagree on which of those 5 factors is absolutely mandatory. For example, the International Diabetes Federation says you must have abdominal obesity to be diagnosed.
But the others don't.
Right, the others say you don't. They disagree on what waist circumference actually counts as obese and whether that number should change based on your ethnicity. They even argue over the exact mathematical cutoffs for blood pressure and glucose.
You know, I was trying to conceptualize this, and the analogy that popped into my head was trying to evaluate a massive storm.
I like that.
So imagine you have 4 master meteorologists standing outside. They all see dark clouds, they feel the temperature dropping, they hear heavy wind, and they see rain.
Right.
But one meteorologist says it's only a severe storm if the wind hits 50 miles an hour.
Yeah.
Another says, no, the wind doesn't matter. It's only a severe storm if we get 3 inches of rain.
Exactly.
They are all looking at the exact same weather system, but applying entirely different labels based on arbitrary cutoffs.
That is a very accurate way to picture it, because the practical reality is that you, as a patient, could get your blood drawn on a Tuesday, and under the World Health Organization definition, you have metabolic syndrome.
Wow.
But if your doctor uses the American Heart Association definition on the exact same day with the exact same blood, you don't.
That is just, how does modern medicine end up with such a moving diagnostic target?
The answer lies in a major shift in how medicine actually approaches the problem. Originally, the focus was mechanism first,
Mechanism first, meaning what?
meaning doctors wanted to identify the underlying biological engine driving the storm, which they believed was a state called insulin resistance. But insulin resistance is incredibly hard and, frankly, very expensive to measure accurately in a standard 15-minute clinical visit.
Right, you can't just take a quick blood draw and get a definitive insulin resistance score on a standard panel.
Precisely. So the institutions pivoted to what is easiest to measure: a standard tape measure for your waist, a basic blood pressure cuff, a routine lipid panel.
So the definition transitioned from a concrete biological mechanism into a checklist based on convenience.
Exactly.
Well, to really understand why those meteorologists are arguing about the rain and the wind, we have to travel back in time. We have to see how the medical community first stumbled onto these connections.
We do.
And reading through the history in the sources, it seems to start back in 1947 with a French physician named Jean Vague.
Vague made a crucial observation that seems really obvious to us now, but it was completely revolutionary at the time.
What did he notice?
He noticed that where fat sits on the body matters far more than how much total fat a person actually has.
Okay.
He categorized patients into having android obesity, which is upper body, or apple-shaped, versus gynoid obesity, which is lower body, or pear-shaped.
And he noticed that the people with the apple shape, the ones carrying weight around their middle, carried a much higher risk for diabetes and heart disease.
Exactly.
But the real mic drop moment, the thing that basically defined the modern field, didn't happen until 1988. An American endocrinologist named Gerald Reaven gives this landmark Banting Metal lecture to the American Diabetes Association.
Yes.
And he proposes a concept he called Syndrome X.
Right, and Reaven argued that a specific cluster of abnormalities, glucose intolerance, high insulin levels, high triglycerides, and low HDL, all shared one single root cause. And that hidden engine was insulin resistance.
Okay, here's where it gets really interesting, though. I have to push back on what Reaven did here, because looking at his original criteria for Syndrome X, he entirely left out obesity.
He did.
He didn't include high blood pressure as a core defining factor either. How on earth could a pioneering doctor look at a metabolic disorder in 1988 and just ignore obesity? That is literally the very first thing anyone associates with metabolic health today.
I know, it is completely counterintuitive until we contextualize what Reaven was fighting against.
Okay, what was he fighting?
Well, he was battling a very entrenched, cardiology-centric view of the medical world. At the time, cardiologists were hyper-focused on LDL cholesterol and smoking.
Right, the classic heart attack risk.
Yeah, and they were largely ignoring the glucose and insulin axis entirely. Reaven wanted to force the medical community to look at this unseen hormonal engine.
He was basically saying, stop looking at the surface level fat, look at what the insulin is doing.
Exactly. He believed obesity was neither necessary nor sufficient to cause the syndrome, and he pointed to a phenomenon that we now call TOF.
TOFI. Thin outside, fat inside. I saw that acronym in the reading, and it honestly stopped me in my tracks.
It is such a vital concept because you can look completely lean in a swimsuit. Your body mass index can be perfectly normal, but you can still have hidden visceral fat packed around your internal organs.
And that hidden fat drives severe insulin resistance.
Yes. Conversely, some people carry a lot of subcutaneous fat, the visible fat under the skin, but they're remarkably insulin sensitive. Reaven warned against reducing this complex hormonal issue into just a syndrome that overweight people get.
But the sources show that Reaven's framing didn't go unchallenged, right? Just 1 year later, in 1989, a physician named Norman Kaplan proposed a competing label called the Deadly Quartet.
Right.
And Kaplan explicitly put upper body obesity back in the absolute center of the picture, right alongside the glucose issues, the triglycerides, and the hypertension.
Yeah, and that 1980s argument between Reaven's focus on insulin and Kaplan's focus on upper body fat is the exact origin of the diagnostic food fight we see today.
Okay, so we have the historical debate down, but what is actually happening inside the body? If Kaplan was right and visceral fat is the starting point of this cluster, how does fat sitting on your belly manipulate the blood pressure in your arms?
Right.
Or change the cholesterol in your veins?
Well, let's follow the biological domino effect because none of these factors arise independently.
Okay, take us through it.
Step 1 begins with that visceral fat. This is the fat stored deep in your abdomen, wrapping around vital organs like the liver and pancreas. And the key mechanism to understand is that visceral fat is not inert energy storage.
It's not just a passive savings account for calories.
No, not at all.
Yeah.
It is highly active tissue.
The reading describes it almost like an endocrine organ, actively dumping free fatty acids and inflammatory signaling molecules, these things called cytokines, directly into the portal vein.
Yes.
And the portal vein is basically the express biological highway straight to your liver.
Which triggers step 2. The liver, now flooded with these free fatty acids, becomes insulin resistant.
Just overwhelmed by the fat.
Exactly. And your muscle cells soon follow suit. Normally, insulin acts like a key. It tells the liver to stop producing glucose, and it tells your muscles to absorb glucose from the blood for storage.
Right.
But under this absolute onslaught of fatty acids, those cells stop listening to the key.
Okay, think of your liver as a nightclub bouncer.
Oh, here we go.
Usually the bouncer listens to the manager, which is the pancreas, who sends insulin over to give basic instructions. But suddenly, the club is completely overwhelmed by these rowdy, chaotic guests. The free fatty acids pouring in from your visceral fat.
I love this.
The bouncer is completely overwhelmed and can't hear a thing. So what does the manager do? The pancreas brings out a megaphone. It starts pumping out massive excessive amounts of insulin just to force the message through all the noise.
That is a perfect analogy.
Yeah.
That state of excess insulin, the megaphone, is called hyperinsulinemia. And a person can walk around with hyperinsulinemia for years, even decades, before their actual blood sugar ever rises high enough to trigger a diabetes diagnosis.
Wow. Decades.
Yeah. The pancreas is working overtime to keep the blood sugar normal. But that excess insulin, combined with the flood of fatty acids in the liver, brings us to step 3. Reshaped blood lipids.
This is where I really needed to slow down in the sources because the mechanism is fascinating. The liver is so awash in fat, it has to do something with it. So it starts overproducing these particles called VLDL, which are just packed with triglycerides.
And here is the biological trade-off that occurs. When the liver pumps out all that triglyceride-rich VLDL into the bloodstream, it triggers an enzyme exchange.
An exchange.
Yeah. The VLDL essentially trades its triglycerides for the cholesterol contained in your HDL particles.
It literally cannibalizes the good cholesterol.
Effectively, yes. The HDL particles become bogged down with triglycerides, which causes them to be cleared out of the blood by the kidneys much faster than normal.
So that is exactly why your HDL drops on the blood test.
Exactly. Meanwhile, your LDL particles, the classic bad cholesterol, also get modified. They become smaller and denser.
And the sources emphasize that this specific combination, high triglycerides, low HDL, and small dense LDL, is called atherogenic dyslipidemia.
Yes.
It is the hallmark fingerprint of metabolic syndrome, and those small dense particles are particularly dangerous because they easily lodge into your artery walls.
Which brings us to the final domino, blood pressure.
Right, so we have the visceral fat, we have the chaotic liver, we have the reshaped cholesterol. How does the blood pressure rise?
It comes back to that megaphone, the excess insulin.
Oh, really?
Yeah, insulin doesn't just manage blood sugar. High levels of insulin overstimulate the sympathetic nervous system.
Meaning the fight or flight response.
Exactly. The sympathetic nervous system tightens your blood vessels. Furthermore, excess insulin forces your kidneys to retain sodium rather than excreting it.
Oh, wow.
And if that wasn't enough, those inflammatory cytokines dumping out of the visceral fat actually block the production of nitric oxide in your blood vessels.
And nitric oxide is what allows your vessels to relax and dilate, right?
Yep. Exactly. This is known as endothelial dysfunction. So you have tighter vessels, more sodium, and an inability to relax the vessel walls. The physical result is high blood pressure.
That is an incredible, terrifying cascade. And the sources give us some really concrete examples proving this chain reaction isn't just like a lab theory. We see it in vast populations, like the Framingham Heart Study.
The Framingham study is a cornerstone of modern cardiology. Started in 1948, it tracked generations of people and provided decades of longitudinal data.
Decades of it.
Yeah, it proved unequivocally that it's the cluster of these factors interacting together that predicts cardiovascular events far better than any single measurement.
We also see the mechanism exposed when populations undergo rapid shifts, right? Like the Pima Indian studies conducted by the NIH.
Oh, absolutely.
They showed how a rapid dietary shift toward calorie-dense, low-fiber Western foods interacted explosively with their genetic predisposition. The diet essentially poured gasoline on that underlying mechanism of insulin resistance, leading to devastating rates of metabolic syndrome and diabetes.
We also see the biology reflected in modern diagnostic adjustments, like ethnicity-specific waist thresholds. In 2005, The International Diabetes Federation recognized that South Asian populations have a much lower waist circumference threshold for abdominal obesity than European populations.
Why is that? Because at the exact same body mass index, South Asian bodies tend to carry proportionally more of that active visceral fat,
Right.
which perfectly illustrates Vague's point from 1947. Body fat distribution is the true driver, not just raw weight on a scale.
So the biology of the cascade is undeniable. But this brings us to the biggest institutional controversy in the field today.
Okay, lay it on me.
Does grouping all of this biology into a single syndrome actually help you, the patient, or your doctor?
I mean, why wouldn't it? If the cascade is real, diagnosing it should be helpful, shouldn't it?
Well, in 2005, there was a massive, highly public rebuke from the American Diabetes Association and the European Association for the Study of Diabetes.
Yeah.
Yeah, it was authored by prominent researchers Khan, Booz, and Ferrani, and it was provocatively titled The Metabolic Syndrome, Time for a Critical Appraisal.
They basically threw a flag on the whole play. Their argument was that telling a patient they have metabolic syndrome doesn't actually predict their risk of a heart attack any better than a doctor just doing the basic math of adding up their blood pressure, their cholesterol, and their waist size using standard medical calculators.
Furthermore, they pointed out a glaring clinical reality. There is no unique medical treatment for the syndrome.
Wait, really?
Yeah, a doctor cannot write a single prescription for metabolic syndrome.
You just treat the individual symptoms, a doctor
Yeah.
prescribes diet and exercise, or they give you a drug specifically for the blood pressure or a statin for the cholesterol. I have to push back on the medical establishment a bit here because if there is no specific pill for this, and doctors just treat the individual symptoms exactly like they always have, isn't this entire concept just an exercise in medical overbranding? Like, why does this debate matter to the person sitting on the exam table?
It is a highly valid critique, and even Reven agreed that the simple checklist diluted his focus on the insulin mechanism. But the defenders of the syndrome argue that medicine isn't solely about biological mechanisms.
What else is it about?
It is also about human behavior and motivation. The label has massive pedagogical value.
Ah, the psychology of a diagnosis.
Exactly. Imagine a patient sitting on that exam table. They have a slightly large waist, their blood pressure is just a tiny bit high, and their fasting glucose is barely elevated.
Okay.
Separately, a busy doctor might look at those distinct numbers and say, well, they're all just borderline. Let's just watch and wait.
But if you group them together under one umbrella,
You realize the house is slowly catching fire. Giving a patient a single unified diagnosis, looking them in the eye and saying, you have metabolic syndrome, can be the psychological wake-up call they need.
that makes total sense.
It is a memorable red flag that motivates early lifestyle interventions before they cross the line into full-blown type 2 diabetes.
Which tackles one of the biggest misconceptions we see in the general public. People assume metabolic syndrome is just another word for type 2 diabetes.
Oh, but it's not. Metabolic syndrome is a risk state. It is the runway leading up to the takeoff.
Right.
As we discussed with the pancreas pumping out insulin, this cascade is happening years, sometimes decades, before your fasting glucose ever crosses the official threshold for a diabetes diagnosis.
This is the early warning system.
Exactly. Many people with the syndrome never progress to diabetes if they intervene early enough.
There is another massive misconception that the sources highlighted, and it goes back to those routine blood tests we talked about at the beginning. Most people assume that when we talk about metabolic health and heart risk, high LDL cholesterol is the main character of the story.
Such a critical misunderstanding. If you look at the criteria we listed at the start, total cholesterol and LDL cholesterol, the classic bad cholesterol that everyone worries about, aren't even included in most definitions of metabolic syndrome.
Which is wild because that is the first thing most people check on their lab results.
I know, but the primary concern in this specific cascade is that unique fatty liver-driven pattern, the high triglycerides and the low HDL.
The cannibalized cholesterol.
Exactly. It means you need to look at the relationships between your numbers, not just the numbers in isolation. If your triglycerides are climbing while your HDL is dropping and your waistline is expanding, that is a cluster signaling a deeper metabolic shift.
Regardless of what your LDL cholesterol is doing. It entirely reframes how we should view prevention. We don't have to wait for a heart attack to treat these as separate, isolated diseases. We can spot the underlying cluster early on.
And the relevance of spotting it early just cannot be overstated. Roughly a third of U.S. adults meet the criteria for metabolic syndrome under at least one of these definitions.
A third.
Yeah. It is one of the most common chronic risk states in modern medicine, tightly tied to our modern environment, our processed calorie-dense diets, and our increasingly sedentary lifestyles.
Wow. We really started today looking at a messy, moving diagnostic target. We traveled back to John Vig, noticing the danger of the apple shape in the 1940s, to Reven's brilliant but controversial Syndrome X, where he tried to warn us about the invisible insulin engine.
What a journey.
Right. We traced the cascade from a flooded liver to the biological trade-off of our cholesterol, all the way down to a tightened cardiovascular system. And we explored the very real debate over whether this label is a clinical necessity or just a catchy brand name for a group of bad test results.
It is a masterclass in how medicine evolves and argues.
Yeah.
And I want to leave you with a final thought to mull over, building on what we've discussed about the actual biology of fat.
Okay, what's that?
If visceral fat isn't just inert storage, but actually acts as a rogue, hormonally active organ, literally pumping out inflammatory chemical signals straight into your portal vein, how much of your daily energy, your mood, and your overall bodily function is being secretly dictated by this alien tissue hiding around your organs without you even knowing it?
An alien organ dictating the terms of your health from the inside out. That is an incredible and honestly somewhat haunting image to end on.
Thank you so much for joining us on this deep dive into the hidden conversations happening inside your body. Keep asking questions, keep looking past the surface of those health report cards, and we'll see you next time.